We're going to talk about specific abdominal trauma injuries now. All right, and we're going to talk about both the solid and the hollow viscous. All right, I'm going to kind of fly through the beginning slides of this because I think there's a lot of talk about DPL that we don't need to dwell on. All right, so blunt abdominal trauma. Okay, blunt abdominal trauma goes hand in hand with blunt thoracic trauma. You got one, pretty hard to not have the other. But a fair number of these will require an operation, okay? And most of them are secondary to motor vehicle collisions, okay? Although motorcycle season is in full swing currently, all right? Just like with any other trauma, remember, start with your ABCs. Don't get distracted, like EMS will try to put a picture of a shattered windshield in front of you. Don't worry about that, okay? ABCs, airway, breathing, circulation. All right, so what are the patterns of injury? On this slide it says spleen 46%, liver 33%. You could kind of go back and forth on this. Okay, some sources will say the liver is more common. It doesn't really matter. Both super common. Okay, spleen is just more likely to result in something that you need to operate on. Obviously gallbladder doesn't take up much real estate, kind of at the bottom of the list. Okay, but we all know what to do with the gallbladder. That one's easy. All right. Penetrating abdominal trauma, again, definitely the liver is going to be the biggest customer here, just because it takes up so much room in the abdomen. Small bowel then is next. That is going to obviously require an operation. Diaphragm, also going to require an operation, okay? Colon, plus minus. If it's in the flank, if you have a penetrating wound to the flank, definitely worry about your colon, okay? Again, we always do our ABCDE. Adjuncts here, I would say, since we had a little conversation about adjuncts to the primary survey, I would say the only adjunct to your primary survey would be a FAST exam, okay, and maybe an ABG. Okay. Secondary survey, again, inspection, palpation, percussion, auscultation. I don't think that you necessarily need to percuss in the trauma bay, but if you want to, that's cool. If it adds something to your decision tree. Okay. The other adjuncts, though, that you're going to need after you finish your secondary is going to be x-ray. Okay? So blunt, we're always going to get a chest x-ray. Absolutely always. Okay? With blunt abdominal trauma particularly, because we don't know if we need to put in a chest tube. All right? Think about a pelvic x-ray. Sometimes I have this argument with one of my partners. I would say that if you don't have signs of pelvic instability, if you are hemodynamically normal and you are going to get a CT of the abdomen and pelvis, you do not need to get a pelvic x-ray, okay? Penetrating trauma, penetrating abdominal trauma, you don't need anything, okay? The only thing you need is potentially a chest x-ray if it's within the thoraco-abdominal region, okay? So if it's near the costal margin, think about getting a chest x-ray, especially if you're not sure if the patient's a little hypoxic. Maybe you're worried about a diaphragm injury and pneumothorax, okay? Think about, though, kind of figuring out where you need to go by identifying where your missiles are, okay? Remember that the number of wounds plus the number of missiles seen on x-ray should be an even number. All right, and think about also placing radiopaque markers if you are getting x-rays for imaging so that you can kind of keep track of where these things are in relationship to each other. Contrast studies, so urethrophy, cystography, definitely if you're concerned for a bladder or urethral injury, these are going to be super helpful. Obviously, if the patient is hemodynamically unstable, they do not belong in a CT scanner or in fluoroscopy. Okay. So, what are other diagnostic studies we can use in blunt trauma? Fast, 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 fast. Okay, focused abdominal sonography and trauma. CT scan, we live and die by it. Okay. Sometimes we'll skip it right away if the patient clearly needs to be in the operating room, but that's somewhat unusual for blunt trauma. And then the dinosaur that is DPL, okay? So we'll talk a little bit about DPL. Rapidly performed. Okay. I would say it's quicker than some other things, right? If you've done a open entry for laparoscopy, you've basically done a DPL, but it is invasive, okay? You need to watch out for the bladder and the stomach and potentially the uterus if you have a pregnant patient. All right. Indications for DPL, none of these here. None of these, okay? Indications for DPL are basically you don't have an ultrasound machine and you're not going to the operating room and you're not going to the CAT scanner. Or you think you might go to the operating room, but you can't pull the trigger and the patient's too unstable to go to the CAT scanner. In which case, you should probably be in the operating room. Okay? But, again, like you can see here, if you have an existing indication for a laparotomy, do not do a DPL. Okay? Just go to the OR. You could go to the OR and start by doing like a little baby laparotomy if that makes you feel better. All right? And again, relative contraindications, prior abdominal surgery and obesity. So already 90% of my patient population is out the door for this, and the rest of them are probably pregnant. Okay? So say you find yourself in the situation where you do a DPL, what are the things that make it positive? Okay? I would say the only thing to remember from this is if it's grossly bilious or it's grossly bloody, you need to go to the operating room. Okay? Anything else, and you just go to the CAT scanner. Okay? Disadvantages. It is invasive. It is overly sensitive and not very specific. You are missing the retroperitoneum and the diaphragm. I would say the other disadvantage is I actually tried to do one of these about a year ago, and getting a hold of a DPL kit took a really long time. Okay? So what is a little bit more palatable for the modern ER? CAT scan, okay? So sensitivity of 90 to 95% that you're going to find something, okay? Might not be what you were looking for, but you're going to find something, all right? So again, what are the indications? Blunt abdominal trauma. A lot of it is going to be mechanism, okay? A lot of it, you cannot send these patients home unless you get the CAT scan. And we kind of make fun of the ER sometimes that they scan everybody, but the reality is if they didn't scan some of them, we'd have to admit them, okay? You must be hemodynamically stable to go to the CAT scanner. A code in CAT scan is not a fun thing, okay? If the patient, however, has unexplained stable hypotension, all right, and I'm going to go ahead and nitpick on this term, stable hypotension, I would say if you have a transient fluid responder, okay, so if you have someone who is hypotensive, but you can get them to improve with fluid, and then as soon as the fluid or the blood stops, they become hypotensive again, that's a patient you can get through CAT scan, okay? Stable hypotension tells me that your blood pressure is 65 and it never gets better, all right? And if that's the case, please don't go to the CAT scanner, okay? Positive abdominal exam, okay? So if you have pain and you're not peritoneal and you don't have fluid on your FAST exam, then yes, you can go ahead and get a CAT scan. If you have an unreliable physical exam, you can go ahead and get a CAT scan. If you've had a previous laparotomy, if you've never had a laparotomy, both of those, you can get a CAT scan. All right? And obviously, if you, for some reason, have an x-ray of the abdomen that's abnormal, that does not include free air. If you have free air, please go to the OR. All right. So let's talk a little bit more seriously about FAST. Okay. So FAST, focused abdominal sonography and trauma. Most of my medical students think it stands for nothing. They just think it's called a FAST. Okay. So what are we using this for? We're using it to find free fluid in the abdomen. And it is not as good. It is not as good as DPL or CT. But what it is it's fast and it's non-invasive. And it's also easily repeatable. Okay? So we can do it again and again and again and again, and it doesn't hurt the patient. It is obviously, like every ultrasound, operator dependent. Okay? So if you're not happy with the results from whoever, get somebody more experienced. Things that can kind of get in the way of the FAST exam, obviously obesity. You've got a lot of fat, then that's more stuff for your ultrasound waves to penetrate through. Subcutaneous air, so in someone who's got a lot of crepitus everywhere, it can be really difficult to evaluate them for free fluid. The indications are the same as for DPL, which is, I mean, honestly, as long as you're not holding anything up, you may as well go ahead and get a FAST. Strict indications for a FAST are blunt abdominal trauma with hypotension. If you have hypotension and there is no indication that you immediately have to proceed to the operating room, get a FAST, okay? Because it can help tell you, is this patient hypotensive because they have 14 rib fractures and they're not breathing, or is this patient hypotensive because they've got free fluid in their belly and we need to figure out what that is. Okay. Oh, it's not on the slide, but I think it's pretty important. 4 views on the FAST. Okay. So, under the liver, okay, Morrison's pouch between the liver and the kidney, corresponding side on the left between the spleen and the kidney, in the pelvis, looking for fluid behind the bladder, and then in the pericardium. Okay, those are your 4 views. What are you not seeing? You're not seeing the retroperitoneum. The other thing you're not seeing is you're not seeing if that free fluid is blood, if it's succus, or if it's ascites. Okay? So those are kind of the problems. And you can see here that the ultrasound can help you to document the fluid if the BP is low, because you can continue to resuscitate the patient. CT scan obviously is not helpful if the BP is low because you cannot get to the patient. Obviously, CT scan costs more, takes more time. Things that CT scan is not good for is obviously hollow viscous injury. Okay, it can tell you there's fluid there. It doesn't tell you if it's blood or if it's from hollow viscous, although the density can be helpful. And also, CT scan is very bad for diagnosing diaphragm injuries. Okay? Ultrasound, same problem. All fluid looks the same. Okay? And it definitely is going to miss a lot of your diaphragm injuries and anything in the retroperitoneum, including the pancreas. Okay? All right. So let's talk about gunshot wounds to the abdomen. Very, very rarely are you not going to operate on someone who comes in shot in the abdomen, but it is possible, okay? So things that are an indication for a laparotomy are peritonitis, hypotension, evisceration. Evisceration is very difficult to treat non-operatively, okay? And peritoneal injury, resulting in peritonitis, okay? Abdominal stab wounds. So especially in someone who's young and muscular, it's actually pretty hard to stab someone all the way into their viscera, okay? So a third of stab wounds are actually going to be confined to the abdominal wall. So frequently we can either, we can establish that they're only in the abdominal wall by doing a local wound exploration or by doing diagnostic laparoscopy, okay? And then if we can determine that there are of the 2/3 that actually penetrated into the peritoneum, then we can go ahead and do our laparotomy, okay? So frequently stab wounds are not going to have actually made it to any real organs, okay? So how do you do this local wound exploration? How do you determine if you're in that 1/3 of stab wounds that doesn't actually get to the peritoneum? So again, a lot of times you're going to end up actually extending this wound, okay? You're going to numb it up locally, betadine it. First thing you're going to look for is if it penetrated the anterior rectus sheath. If it didn't get to the rectus sheath, you are done, okay? If it got to the rectus sheath, I would say if the patient is hemodynamically stable, or if for some reason you didn't do a local wound exploration, I would say next step would be a diagnostic laparoscopy, okay? If you do a diagnostic laparoscopy and the peritoneum is totally pristine, then again, you're done, okay? If it violated the peritoneum, or if you do your local wound exploration and it violated the peritoneum, then you can convert to a laparotomy, all right? Sometimes you can get away with just doing serial abdominal exams, especially if it's off closer to the flank, okay? And you can do just serial exams for these patients without subjecting them to the wound exploration. All right? So that is operative stab wounds. All right, blunt abdominal trauma. So blunt abdominal trauma, I think, is sort of the black box, right? We don't know who we should operate on and who we shouldn't. Gunshot wounds is pretty easy, but blunt abdominal trauma, it can be hard. So that's why we have so many modalities that we kind of add up, right? Frequently you're going to get an ultrasound and a CAT scan, and you're going to look at their hemodynamic situation. If they're hypotensive, just don't let the abdominal wall stand between you and a diagnosis, okay? If they're hypotensive, even if their CAT scan looks okay, or you're like, oh, maybe there's a little bit of fluid, go ahead and rule it out. Remember, CAT scan is very bad for assessing small bowel injury and large bowel, okay? Don't rely on CAT scan to tell you there's not a hole in the jejunum, especially if your patient is unstable. All right, and if you find yourself continuously giving fluid, right? Every couple hours you're giving another fluid bolus, you probably belong in the operating room. All right, obviously if your patient has peritonitis, take them to the operating room. Obviously, if your patient has free air, take them to the operating room. All right. The other radiologic finding which you need to be worried about is an intraperitoneal bladder injury. Okay. An intraperitoneal bladder injury means that your viscera are being bathed in urine and that you had a lot of transmission of force to that area. So you need to go in and fix that and rule out any other injuries. Okay. So let's talk about the diaphragm. Diaphragm is kind of interesting. Can be injured by both blunt and penetrating mechanism, which sometimes people forget about. Chest x-ray, you can look at that. That number is all over the place, okay? So don't rely on your chest x-ray. Okay. So, I mean, sometimes it's going to be really, really specific, right? If it's the classic, the NG tube is up on the left chest, right? Then it's pretty specific. But a lot of times it's not going to be quite so clear. CAT scan, again, very infrequent that it will be reliable, okay? If you have the only real true sign that imaging is going to give you is if your abdominal viscera are up in your chest. Think about diagnostic laparoscopy. So say you have someone who has a diaphragmatic injury or you're concerned has a diaphragmatic injury. If they are not hypoxic and they are not hemodynamically unstable, think about putting a scope in and looking at that diaphragm, especially if they're big, okay? Because it's going to be a lot easier, all right? Remember, though, that some of your gas for your laparoscopy is going to go through that hole in the diaphragm if it's there, all right? And so you have to tell your anesthesiologist about that, and if they don't have a chest tube, be ready to put a chest tube in, okay? So diagnostic laparoscopy can be useful, and you can fix these laparoscopically, okay? And that can be obviously beneficial to the patient. How do you want to fix your diaphragm? There's really no wrong way to do it. It's a pretty forgiving organ. Okay, this says heavy non-absorbable suture. I mean, you could use Vicryl. It's totally fine. You just have to get something that's going to get the two edges together. Some people will use pledgets. Some people don't use pledgets. Some people do running suture. Some people don't do running suture. It's fine. Okay. If they truly have a blowout of their diaphragm, you will potentially need to bridge it with a mesh. Okay. Either, probably in the case of trauma, you're going to want to use a biologic mesh, okay? So filling in those holes with Stratus, all right? Remember that anything that perforated in your abdomen is now shared by the thorax, okay? So gastric contents in the chest, those need to be washed out, and you need to place chest tubes, okay? That patient's going to have an empyema. All right, stomach. So, usually, how do stomachs get injured? Usually with penetrating injury because they kind of flop around, so it's kind of hard for them to get injured by blunt injury. Again, a pretty forgiving organ. Takes a stapler well. You can just fire a stapler across it, or you can fix it with 1 or 2 layers. The key here, though, is examining the posterior wall. So if you have an anterior injury to the stomach, especially penetrating, you need to open up that lesser sac, and you need to inspect that posterior gastric wall. If you have a big enough anterior injury, you can look at the stomach through the anterior injury to the posterior wall. But I think it's really good practice to open up the lesser sac and ensure yourself that you don't have a through-and-through injury to the stomach. Okay. Irrigation for contamination, and remember to have your anesthesiologist place the NG tube before you do your repair. But don't staple it in. Okay? All right. Small bowel injury. You know it. You love it. We got a little bucket handle defect down there. Okay, there's no place for non-operative management of small bowel injuries. Okay, so we talked a little bit initially about exploring hematomas. Remember that you don't want to explore simply mesenteric hematomas, but you want to control mesenteric bleeding. If that hematoma has already controlled the mesenteric bleeding for you, you don't need to go disrupt it. But you do need to explore any hematoma that is over the surface of the bowel, because you want to make sure that there is not a hole in the bowel living there. Okay? Obviously, these are very easy to resect most of the time. You may find yourself actually resecting a fairly large portion of bowel, and it can be a little nerve-wracking. Try to minimize the number of anastomoses that you do, especially if you have something like this where the blood supply is potentially limited. Okay? If you have any questions about it, go back to your damage resuscitation principles. Okay? okay? If this patient is hypotensive, remember, don't spend your time doing an anastomosis. Control the contamination, control the bleeding, pack them, come back and see what's dead the next day, come back and see if it's dry, come back when their acidemia is fixed and they're actually going to clot, okay? Perioperative antibiotics, it's going to be the same as if you were doing an elective bowel case, okay? You're just going to use your skip antibiotics. There's no benefit to prolonging it, okay? Colon and rectum. So typically these are going to be penetrating injuries, although it is common to have mesenteric injuries to the transverse colon. Treatment controversial. So I would say the controversy here is obviously ostomy or no ostomy, right? But the literature here does back up that we can be pretty aggressive, especially with penetrating injuries, in early anastomosis of these patients. Again, if you are in a situation where the patient is hemodynamically unstable, staple, don't do an anastomosis, don't make an ostomy, leave them in discontinuity, pack them, take them to the ICU, okay? There's no need for spending time doing an ostomy or maturing an ostomy or doing an anastomosis, okay? Frequently, these colon injuries, especially if it's in a hemodynamically stable young patient, you can actually just oversew them, especially if they're just a small amount of the circumference, okay? If you do a segmental resection, or if the patient has a complex perianal soft tissue injury or an open pelvic fracture, that's when you need to think about doing an ostomy, okay? If the patient has an open pelvic fracture or open wounds in their perianal area, that is a good indication that you need to do an ostomy. Things that you shouldn't do: presacral drainage, doesn't help anything. Distal washout of the rectum, again, not helpful. Okay. Pancreas. All right, so this is a nice little image of a pancreatic transection with the help of a giant yellow arrow there. Okay, and we can see that this patient probably would have had a positive FAST exam, because on that left kidney, we can see there's a bunch of fluid that would have been floating around between the kidney, the tail of the pancreas, and the spleen. Okay, so pancreas actually is pretty common to be injured both from penetrating and blunt mechanism, and it's because it's sort of fixed in place back there against the T-spine, okay? So it gets kind of smushed, especially by seat belts. 50% of these have other associated organ injuries, okay? And that can include spinal injuries, so an L2 fracture, okay? Think about pancreas. How do you diagnose these? Obviously, your diagnosis is mainly going to be by operating, okay? So anytime you're curious about it, right? So say you go back to that stomach injury and you're looking at the posterior wall, you're right there. Look at your pancreas. Make sure it's okay. You're doing a splenectomy, look at your pancreas. Make sure it's okay. All right? Like it says here, the integrity of the main duct is really critical, okay? Everything in the pancreas is made to digest steak and broccoli, okay? So we don't want it floating around on our new colonic anastomosis. All right, so again, if you're at laparotomy for other injuries, when you're doing a splenectomy, always look at the spleen. Always have a high index of suspicion. If you're doing a stomach injury, look at the spleen. If you are in the leftover quadrant for any reason, look at the spleen. Okay, amylase is not that helpful. Again, DPL and FAST are not reliable because they're not going to tell you what kind of fluid it is, and you can't get to the retroperitoneum. CT scan. So this is actually kind of true. So repeat CT scan. Say you did a splenectomy and you left some drains and you weren't really sure. Going back and doing a repeat delayed CAT scan is going to help you to delineate that pancreatic injury much more than your early injury. Okay? So if you're concerned about that main pancreatic duct, do the same things you would do if you were concerned about a pancreatic duct on a general surgery patient. So get an MRI, get a pancreatogram, okay, or get an ERCP. The benefit of ERCP is that if you do have a main duct injury, they can potentially stent it, okay? So they can help you to delineate where the injury is, if there is a pancreatic duct injury, and they can potentially help you stent it. Again, this is something you're going to need to explore in the operating room, and you're going to have to think about while you're in your laparotomy, all right? So say you're in there and you find something. What do you do about it? Okay, so we had a little pancreatic bruising, a little bit of a laceration, gentle debridement, super gentle, okay? Those 3 rules of surgery, they still come into play here, okay? So we want to obviously remove any necrosis that we have, but we don't want to over-debride. You can think about where over-debriding probably gets you. It probably gets you a pancreatic leak, okay? Wide drainage, just like in a general surgery case, is going to be one of the other principles of taking care of a pancreatic injury. When in doubt, leave some drains. They can always come out later. Okay, the last thing you want is uncontrolled pancreatic leak. All right, the key landmark here, too, is going to be your superior mesenteric vessels, okay? If anything is to the left, okay, to the patient left of your superior mesenteric vessels, you can do a distal pancreatectomy, okay? You can do it with or without splenic preservation. If you have a reason to preserve the spleen, that's great. If the spleen is injured, take it out with it, okay? But anything distal to the SMA, thank God, because you can just treat it with a distal pancreatectomy. You can oversew that staple line. You can leave a lot of drains. If you want, leave a J-tube for feeding, okay? Anything to the right of that is a major problem, okay? That you're going to leave a lot of drains and you're going to ask for a lot of help. Because what do we never do in trauma? We never do a Whipple unless the trauma did the Whipple for you, okay? This is a major issue, okay? So don't go digging in this area, okay? You're going to have a lot of bleeding and you're going to create more leak, okay? So try to leave things alone, widely drain, establish other feeding access, staged surgery. So the first step is drainage. The first step is creating a controlled fistula situation, potentially getting an ERCP and seeing if you can prevent any hyperbilirubinemia, and then coming back later, preferably with the help of a experienced pancreatic surgeon. Okay, so we talked a little bit about duodenum earlier and how we should always explore the duodenum, okay? Blunt or penetrating, if you have a pancreatic injury, you need to think about the duodenum. What is the most commonly injured portion of the duodenum? It's that C loop right there, okay? It's a little less protected than the other portions, okay? Typically, though, it's going to be going along with something else, so you're going to find this when you're in there for something else. You're going to find it when you're in there for your splenic injury or your pancreatic injury or your small bowel injury, okay? You're going to see a lot of fluid on your Morrison's pouch view on your FAST. Again, you have to have a high index of suspicion, and you have to look for that hematoma. But if you're in the OR and you see that hematoma, you need to explore it. If you get a CAT scan and there's a hematoma on the CAT scan, okay, if you see contrast or air leaking out, you probably should go in and fix it. If it is just a hematoma, we'll get to that, okay? All right, so say you just have a hematoma. This is probably what it's going to look like. It's going to look just like a lot of like murky little stuff, okay, on the cross-sectional view. Stack of coins, I guess. I mean, I can't really see the stack of coins, but frequently it's just going to look like there's a lot of muck around the duodenum. The patient that you need to be suspicious for this in is anybody that went over some handlebars. So frequently a little kid, but sometimes also a bicyclist or a motorcyclist. Anybody where they had an impact to their epigastric area, okay? So think about it too in someone who has an L1 fracture. So if it is just seen on CT, you do not necessarily need to take this patient to the OR. If there's no free air, there's no contrast leak, you do not need to take this patient to the OR. But what you do need to do is you need to be extremely patient, and you have to warn the family, okay? Because this is going to be like a very long road, okay? Just like establish a good relationship, because you and this patient are in it for 2 or 3 weeks, okay? And they're going to have an NG tube, and they're going to be NPO, and they're going to be on TPN, and you're just going to be sitting there, and the parents are going to be like, when are you going to do something? And you're going to be like, not now, okay? And that is the best course of action. Okay, if you are already in the OR, though, remember, you have to explore that duodenal hematoma. Because if there is a perforation, you can fix it, okay? So, if there's a perforation, you go ahead and fix it. You evacuate the hematoma. If it is between the layers, right, so say it's in the serosa, make sure that you don't violate it, because you can convert these partial injuries to a complete one, okay? I mean, if you make it complete, like, whatever, we'll fix it, but, like, try not to. All right. So remember, if you get that CAT scan and there's free air or free leak of contrast, you have to go to the OR. Okay, that's a perforation. You have to go to the OR. So try to close these perforations transversely, okay? Try to trim them up, get all that dead tissue out, close them transversely so that they don't cause stenosis, all right? 1 or 2 layers. I mean, if it's less than 50%, a lot of times if it's a young, healthy patient, even just 1 layer, you'd be surprised how quickly it heals. Provide drainage, okay? If it leaks, you want it to have a conduit to not cause contamination. Retrograde jejunostomy. Okay, so this isn't always called retrograde jejunostomy. A lot of times this is called triple tube technique. Okay, so what you're going to do is you're going to have a gastrostomy tube, okay, either an NG or a surgical gastrostomy tube, and that's going to be for drainage of the stomach. You're going to have a regular jejunostomy tube, and that's going to be for feeding distally. And then you're going to have this other jejunostomy tube that's going to sit slightly more proximal, okay, slightly closer to the ligament of Treitz than your feeding jejunostomy. And that tube is going to snake back into the duodenum and provide internal drainage to the duodenum, okay? So what you can do there then is you're draining the stomach, you're draining the duodenum, and you're feeding distally, all right? Other options, say you go ahead and fix this perforation, but you're a little worried about it, it's a little tenuous, you closed it in the wrong direction like this person did, okay? You didn't follow the principles where you close it transversely. Say that you're worried about it and you want to make sure that that thing heals really well. What can you do? You can divert your food stream, okay? So you can do a pyloric exclusion. So what you're going to do is you're going to make an incision like you're going to do a gastrojejunostomy, because you are, and you're going to reach your little Babcock clamp through that jejunostomy and you're going to grab the pylorus, okay? And then you're going to close the pylorus. You can either close it with suture or you can close it with a TA stapler, all right? So now the stomach has no outlet until you create your gastrojejunostomy. So you've made a gastrojejunostomy and the food is going to be diverted there while your duodenum heals. Eventually, in about 6 weeks, this will all open up. And hopefully at that point, your duodenum will be well healed. Okay? All right, so spleen. Spleen is probably the solid organ that you're going to operate on the most for blunt injury, okay? Again, this says most frequently injured. You could kind of go back and forth. Is it more commonly injured than liver? Whatever. All right. So CT scan is really, really helpful in this, obviously, okay, because it can establish, is the spleen injured? Where is it injured? What's the grade? If your patient is hemodynamically unstable, spleen goes in bucket, okay? The grade of injury on the CT does not determine what you do. The patient determines what you do, okay? The majority of these, though, can be managed non-operatively. All right, so you guys have probably all seen this before, and we'll go through the AAST, American Association for the Surgery of Trauma injury scales. They like to scale everything, like literally. They have, like I think they actually have an ovarian injury scale. I'm not kidding, okay? So, but it goes the same way on all of them. So don't waste too much brain power kind of memorizing each of them individually. Grade 1 is always going to be something less than 10% that you probably wouldn't know was there if you didn't have a CAT scan. Grade 5 is always going to be something that is either completely shattered or goes across the hilum. So this is universal for all solid injury scales. Grade 3 is going to be what I always think of as the dividing line, okay? So grade 1 and 2 are typically minor, rarely require transfusion, very, very rarely require intervention. Grade 3 is where things start to get hairy, especially if you have an anticoagulated patient or an older patient, okay? So grade 3 is where we start to think that someone might need something done. And it's typically, as with the spleen, it's going to be a subcapsular hematoma covering over 50% of the surface area, or a hematoma that has broken free from the capsule. Okay, so if it's not just contained, then you're already at grade 3. Okay? So grade 3 and 4 are where we have to do something most commonly, but that doesn't mean all the time. A lot of these can still be managed non-operatively. So again, think about your ABCDs, always, always, always. Think about, in the unstable patient, just getting a FAST and seeing where that fluid is. Now, just because the fluid is on one side or another in the FAST, that doesn't determine what organ is injured, okay? But it can help guide you to whether or not you need to be in the abdomen or in the chest, whatever, okay? Non-operative management. So, advanced stage and associated head injury are not contraindications for non-operative management, but remember that those patients are not going to tolerate hypotension. So you might need to be a little bit more aggressive about taking that spleen out rather than sending that patient to IR if they have an associated TBI. Okay? Failure correlates with grade of injury and amount of hemiperitoneum. So this is sort of intuitive, right? If they have a grade 4, they're more likely to fail non-operative management than if they're a grade 3. Okay, so I'm sure you guys have all had a patient who got their spleen embolized. So this is really something for someone who has a severe injury with active extravasation on your angiography, but they're stable enough to be in IR, okay? Now, we definitely push the limit with this. We'll send someone who's a little tachycardic, who's getting some blood, but generally speaking, they have to be stable enough to be in IR, okay? And obviously, they have to have a target, so they have to have some sort of active extravasation on their initial CT. So this is typically going to be someone who has a grade 3 with a large hemiperitoneum or grade 4. Preserved immunologic function. So obviously these patients are going to hopefully still have some functional splenic tissue, and that's going to be a huge benefit to them. They're not going to be so susceptible to those encapsulated organisms. Now, you notice that grade 5 is not up here on this, okay? Are there patients out there with grade 5 splenic injuries who get embolized? There are. But in general, grade 5 is probably going to be in the OR. Okay, so this is kind of what your splenic injury is going to look like. You can see that there's some intracapsular kind of deficits within that spleen. I don't see any contrast extravasation, but we do see a little bit of free fluid around it. Okay, there's one, grade 2. So hopefully this was incidentally identified because a grade 2 injury should not necessitate a laparotomy. And you can see there that it's completely hemostatic. Okay, unlike this one. Okay, hopefully that one was going in the bucket. But it doesn't look like it's actively bleeding. It's just got a lot of clot around it. All right, so why do we worry about taking the spleen out? Why do we give up this territory to the interventional radiologist? Okay, it's because, especially in kids, we can get that overwhelming post-splenectomy sepsis. Okay, so more common in children, not very common overall, but when it does happen, it's very, very, very high mortality. Okay, so remember Pneumovax, H-flu, and meningococcal vaccines. This says 2 weeks post-op. Obviously, as you guys know, there's no distinct best post-op time to give these vaccines. I certainly wouldn't keep someone in the hospital for 2 weeks. If I thought they were unreliable, I would try to give them to them whenever I thought was the best time based on my judgment. Remember, too, that the Pneumovax, you need a booster shot. So you have to find that patient and get them their booster shot in 5 years. All right? Okay. So let's talk about the liver. Liver's a big player, obviously. Takes up a lot of space, very commonly injured. Problem with the liver, can't take it out. Really problematic, okay? So operative intervention is going to be based on hemodynamic stability, again, just like everything else we've talked about in the belly, all right? And the majority of these patients are not going to need an operation, including potentially patients who have penetrating injury, okay? So AAST scale, again, it's the same. Grade 1 is less than 10%, something you probably wouldn't have even noticed. Grade 5 here is a little different because there's no one hilum, but you can see that it includes 3 segments, or 75% of a lobe, and it can include juxtahepatic venous injuries. Okay. Grade 6 is complete hepatic avulsion and is probably a non-survivable injury. So just like with the spleen, grade 3 is sort of the dividing line. So that's where things are kind of getting serious. We have greater than a 10-centimeter hematoma, or the hematoma has ruptured from the capsule, so it's more freely bleeding, and that's probably where we're going to have to do some interventions. Okay, so something like this. This is a pretty deep laceration. Goes almost through and through. You can see that this patient almost took out kind of the right side of the liver there. Okay, and it's kind of displaced some of the left side of the liver medially if they hadn't eaten a full meal beforehand. Okay, this is like the rule of trauma is the patient comes directly from a buffet. Okay, so every stomach is massively full. Okay, but this is a much less severe injury, and you can see that somehow it managed to avoid those big hepatic arteries over there. Maybe a little blush in that one, but otherwise a much less severe injury. Okay, there's one that is magically hemostatic, more magically hemostatic. Okay. So, non-operative treatment of the liver injury, again, just like everything else, depends on absence of peritoneal signs, lack of transfusions, and hemodynamic stability. If you're transfusing again and again and again in order to achieve hemodynamic stability, then you need to be doing something else, okay? First thing you might think about doing is angioembolization, okay? So if you have a blush on your CTA, think about angioembolization because it's going to be much easier for your interventionalist to get to any of these things than it is for you in the operating room. So you can see here that there was a big blush off the right hepatic artery, and then they've embolized it, and it has stopped. All right, so non-operative management is going to be used in most liver cases. The problem is that, and we'll talk about this in a minute, is that liver injuries are pretty difficult to treat operatively, and we don't really always have good options. But angiography and embolization are going to be your go-to if the patient is sort of towing the line. Remember, bed rest, not useful. I would say also not useful in splenic injuries. Okay, if getting up and walking to a chair is going to result in your patient getting an operation, they probably belong there in the meeting. Okay? All right, so say you are forced to go to the operating room for the liver. Okay, it can be a little difficult. So the first step is getting adequate exposure. All right, so you're going to break out your big retractor, right? You're going to get your Omni or your Thompson or whatever you're used to. And you're going to think about, this says extending to a sternotomy. Remember, if you have a retrohepatic caval injury, do not explore that hematoma unless you are absolutely forced to. If you are forced to, get ready to divide the sternum, split the diaphragm, and go into the chest. If you have a big liver injury, just like anything else where you're in the belly for trauma, the first step is packing. And the key to the liver is not just to pack on top of it, but it's to pack under it. So you sort of make this liver sandwich, okay? What's the next step? The next step is to do your Pringle, okay? So the Pringle is going to be very, very helpful. I don't think they have one here, I can't tell. Oh, it's that clamp, I think. Okay, so the Pringle is going to be very, very helpful in having you get control of your bleeding because you can kind of pull on it, buzz a little bit, suture something, and then take it off, okay? All right, so packing, you can get rapid tamponade, even manual compression, hold those packs down, okay? Definitely if you wind up in the operating room solely for a liver injury, think about using your damage control principles. So the only goal is to stop bleeding. If you have to leave the packs in, do it, okay? And the one thing you can do is you can leave the packs in, you can leave the patient's belly open, and you can take them to angiography like that, okay? If there's still something bleeding with all those packs in place, it's going to be really deep, it's going to be really large. Get your interventionalist help, have them embolize it, and then take them back the next day, take your packs out, get all the other stuff that's bleeding, okay? So remember with your Pringle maneuver, there's a nice photo of it. 15 minutes on, 15 minutes off. I mean, no one's done this research, right? We don't have a randomized control trial of how long you can leave a Pringle on for a trauma. Okay, not that I'm aware of at least. Okay, but do it so that as long as it takes to control the bleeding, or at least get some semblance of control with packs. Okay, and you can leave your vessel loop on for a while, just loose. Okay. Other techniques that you can use, okay, so finger fractures. So just taking your fingers and kind of pinching them apart and almost making that liver injury a little bit deeper will kind of fillet it open so it's not a deep, dark space. And then you can clip stuff, you can bovie it, you can oversew it, okay, and you can also clip off any little bile cannula type things so that you don't get a bile leak. Staplers, so you can use a vascular stapler, fire it across the lobe of the liver if you need to, and do a non-anatomic resection. High energy devices, so anything that your liver surgeons use to resect, right? Whatever brand, Covidien, Ethicon, whatever, take it, fire it across, and then think about your topical agents too. So once you've got the bleeding somewhat controlled, flow seal, gel foam to seal, all that stuff, pile it all on there. Okay, just stop the bleeding. All right. So what are the problems that we see down the road with liver injury? Say you successfully got the bleeding stopped. Patient is closed. Okay. What are the things we worry about? So definitely recurrent bleeding. Okay, they get up, they go to the chair, and then they bleed. Okay, back to the OR. Or angiography. Okay, remember that post-op bleeding, you can do angiography, even with packs in place. Hemophilia, okay, patient suddenly starts getting jaundice, right? And then we're worried that there's a fistulization between the liver and the I can't talk anymore. Between the blood supply and the biliary channels of the liver, okay? Angiography, potentially sometimes you need ERCP for that if there's a big bile leak, okay? Abscess and myeloma. So this is a big problem too, because what's going to happen with the liver is you're going to stop the bleeding, and then some of that liver tissue is going to become necrotic, and it's going to get infected, especially if you had a concurrent like GI injury, stomach injury, or small bowel injury, or what have you. Even gallbladder injury, right? So all of that necrotic liver tissue will potentially turn into an abscess. You will need to potentially do pancreatic percutaneous drainage or ERCP if they have a big bile leak, okay? Frequently both if they have a very large bile leak. I would say if you have a big laceration to the liver, always leave drains at the time of your final operation, anticipating either an abscess or a myeloma or potentially both, okay? So let's talk about the other solid organ, the one that sometimes we forget about, which is the kidney. Okay, so this is the most likely GU organ that is injured because it's obviously much larger than your ureter. Okay, occurs pretty frequently in both blunt and penetrating injury. Okay, we also have to worry about the vascular supply, like we kind of talked about in the first lecture, because it is a little bit dependent and because it's very blood pressure sensitive. Okay, so hematuria, we always have to be aware of it. We have to have a high index of suspicion, right? We talked about with pelvic injuries, anytime we have hematuria in the setting of a pelvic injury, we need to take it very seriously. But the absence of hematuria does not correspond with a lack of injury either, okay? So this is in trauma we love algorithms, okay? It's like kind of how we think, all right? So if you have hematuria and you have a penetrating injury, you need to immediately assume that you have a renal injury that goes through to the calyx, okay? If they're stable, though, this is one of the few situations in which you can get a CT scan for a penetrating injury, okay? If they're not stable, there is no role for CT scan, okay? So here we'll talk about one-shot IVP and exploratory laparotomy. IVP is something that can easily be done in the OR, right? You just give contrast and time your x-ray appropriately. Whether or not you feel comfortable interpreting that IVP is slightly different. You may need to have your urologist help with that, okay? Even if you see a retroperitoneal hematoma, if it's not expanding and it's not pulsatile, remember, you don't necessarily need to explore it, okay? For blood injury, okay? So how are we best going to delineate what is going on if we think our kidney is injured? It's not going to be the one-shot IVP, okay? It's going to be your CT scan, because the CT scan is going to allow us, if we give contrast, to kind of observe the kidney at all stages. So it's going to tell us if there's a artery injury, if there's a parenchymal injury, and then if it's flowing into the ureters and if it's filling the bladder as well, okay? So it can tell us if there's devitalized segments, or if there's a urine leak. All right? So I would say always, there's no real role for getting the CT without angiography. MRI is not helpful. Sonography, it might be useful in your postoperative care, but no role initially. Okay. So this is obviously a very, very injured kidney. We probably didn't need our CTA to tell us that, but you can get a nephrogenic phase to determine whether or not there's arterial extravasation. Okay, and that's apparently going to be 80 seconds after contrast. But you can see the contrast there in the aorta, so that's obviously the arterial phase. And then you can go on to do your delayed scans. So you can time them to be in the renal pelvis. This says can omit delayed films. I mean, I've never regretted getting a delayed film, but I have regretted not getting them, okay, especially in the situation where you're in a potential renal injury, because you want to make sure that that contrast flows all the way down through the ureters and that you see it in the bladder, okay? So your IVP, obviously this is something that you would only do if you were unable to take this patient to CT or if you were unable to explore this hematoma. You know, giving contrast in the operating room and interpreting the images right there is only useful in a very, very specific situation, okay? But it can potentially mean that you don't need to go after a stable hematoma, okay? So say you've got a penetrating injury, you have a non-expanding retroperitoneal hematoma, or maybe you've explored the colon portion of this, but the kidney kind of looks okay, you want to make sure, should I leave the OR without doing anything? Maybe not. Okay, you can get the IVP, you can ensure yourself that there's no big urine leak, and you can feel better and leave, okay? But a urine leak that's contained is also something you can treat post-op with either stents placed by urology or nephrostomy tubes, okay? So once again, we have our AAST injury scale, okay? And again, you can tell that this follows a pattern. So grade 5 is completely shattered and across the hilum, okay? So that's that first CAT scan that we looked at. That patient, it looked like that kidney was pretty free-floating inside that hematoma. All right, grade 1 is something, if you didn't look hard enough on a CAT scan, you probably wouldn't even know was there. All right, so the difference here is that grade 3 is a little less of the dividing line here. So grade 3 is not yet into the collecting system, but grade 4 is where you're into the collecting system. Okay, so grade 4 is where we get a little more concerned. However, grade 4 still does not mean that you have to operate. Okay, you don't have to operate just because it went into the collecting system. Do stable grade 5 renal injuries exist? I mean, that would be pretty remarkable. I would say probably not. Okay. So grade 5, you probably are going to be exploring that patient. They're probably going to have other injuries anyway. Grade 4, if that's the only injury, you do not necessarily need to operate on that patient. They can still be treated non-operatively. Okay, so what are the principles of non-operative management? Just like any other solid organ injury, okay? If they're hemodynamically stable, it's all good. If they're not hemodynamically stable, we need to be doing something, okay? But it does mean that people get less nephrectomies, all right? And that's pretty important. All right, so the thing to remember is that even with the urinary extravasation, they're probably going to heal pretty well, okay? The calyces are pretty forgiving, okay? And it's a low-pressure system, so a lot of times it actually does okay. And remember, too, that you can always have urology, if they think it's appropriate, put in a stent, okay? To stent or not to stent, I would say stent if you can. So what are the indications that you absolutely need to operate on this patient? Obviously, if they're unstable, if they have a pulsatile renal hematoma, that pulsatile expanding zone 2 hematoma, you got to go after it, right? Because it could be the renal artery. If you have a suspected renal pedicle injury, if you think it's a grade 5 across the hilum, that patient is probably going to be unstable, and you're probably going to be going after it anyway, and they're probably also going to have the expanding renal hematoma. Or ureteropelvic junction disruption, so if that ureter is just floating in the breeze. This is going to be hard to find in the OR, okay? Probably you're going to have found this on your CT, okay? Relative indications are the urinary extravasation, but again, non-operative management is still an option there. Renal laceration with colon pancreatic injury, Kind of depends on what you're doing with the other organ injury, to be honest. All right, because that's probably going to determine the kidney is a little bit secondary there. Okay. If for some reason there's an arterial injury that is delayed, say maybe it's an intimal flap or something like that, that's a little bit different. If that kidney is already ischemic, it's probably going to result in a nephrectomy. Okay. Incomplete staging. I don't really know what that means. I guess it means that potentially the stage is unclear from the CT scan. But again, if your patient is unstable, go to the OR. Okay. So what are the options for controlling bleeding from the kidney pedicle? So you could do what we think of when we expose the retroperitoneum, right? Which is mobilize the white line of Tull, flip everything over. But if you're really concerned that you have a pedicle injury, you can actually incise the peritoneum and actually get control more proximally before you open that hematoma. Okay? And we can get an argument about what is faster. And 6 trauma surgeons would say one thing and 6 trauma surgeons would say another. But if you have a contained hematoma that you're going to uncontain in a second, it's probably worth a shot to go get some vessel loops around this before you make it an uncontrolled situation. Okay, so you incise near the aorta, okay, and just get some vessel loops around to take off every renal artery. Okay. So renal reconstruction. So the good thing about the kidney is you can repair it. Okay, so you don't always have to be doing a nephrectomy. Okay, especially if it's isolated to one pole of the kidney. So sewing in the kidney is sort of like sewing the spleen. If you guys have ever sewn the spleen, it's kind of friable. It doesn't have a lot of flexibility. Okay, but you can close it. So you're obviously going to completely expose the kidney, get all that Gerota's fascia off, get it up in your hand, have proximal and distal control. Okay, get rid of any non-viable tissue, especially if it's a gunshot. Okay, it's going to have a lot of blast injury. Okay, and then if you can see the collecting system, you're going to close the collecting system. Okay, and then you can cover it with anything that's around, pretty much. But omentum comes into play here, or you can do a partial nephrectomy, or you can sew up the repair, like you can see here. Now, it's pretty useful, I think, to use bolsters here, because the kidney is, if you don't get the capsule with it, it's very difficult to keep your stitches in place. So you're going to want to use pledgets, but like use them in a strip, not a little piece. Okay, and then use your horizontal mattress sutures, and you can come across, you can try to squish down that lower pole and try to sandwich it and then sew some pedicle on it, or if it's something like this, you can try to bring that defect together. Even if you don't close the collecting system, just doing this will probably help. Okay, so not everything needs to end in a nephrectomy. All right. Superselective embolization, just like with the spleen, sometimes they can embolize the kidney without sacrificing all of it if there's an appropriate target. Okay. So ureteral trauma. It's very uncommon, but it's something that we think about a lot because you have to have a high index of suspicion, kind of like the esophagus. You have to look for it, and if you don't look for it, it's very morbid. All right, so what do people get? They obviously get urinomas, and they get strictures, and they get all the things that come with ureteral injury that we would associate with, colon surgery or whatever. Okay? If they're delayed or missed, there's an increased risk of nephrectomy rate. And remember, blast effect. So we just kind of talked about that a little bit with the kidney. With the ureter, it's actually even more fragile to that blast effect. So if you have a gunshot injury, anticipate that you're going to have more necrotic tissue than you do initially see with your own eyes. It's going to kind of declare itself. So up to 2 centimeters of microvascular damage, according to this paper from 1970. Hopefully I have something more up to date. Okay, so how do we diagnose it? Potentially hematuria, but remember, lack of hematuria does not rule it out, okay? Think about your trajectory with penetrating injury. Where do we think that bullet or knife went? Okay, and that may be the only thing. So you really have to explore that ureter, okay? Pre-op imaging, get those delayed films, okay? Wait for that contrast to go into the ureter and follow it down. Methylene blue, so you can always inject methylene blue and try to look for it if you can't find the ureter. But again, the important thing is to maintain a high index of suspicion and explore for the ureter. Just like you would never do, colon surgery without looking for the ureter. If you think it's there, you need to see it. If you're suspicious that there's a ureteral injury, make sure that you see a completely normal ureter, okay? So imaging, there's no perfect study, but I would say CT with delayed films is probably getting better and better, okay, as our CT technology advances. IVP, our ability to actually interpret those IVPs is probably going down as our CT technology increases. So maybe a urologist would be better at it, but certainly they can do them via cysto, and that's pretty reliable, probably more reliable than a regular single-shot IVP. Okay, and ureterography, so done by a urologist with cystoscopy. Okay, so there's our little ureters. They look so happy. Okay, so what you're going to do to fix the ureter is really going to depend on where it is. Okay, so remember the upper third of the ureter is closer to the kidney, and it's going to be divided by, so the division here between the middle and the lower third is going to be based on the pelvic brim. Okay, so above that, below the pelvic brim is the lower third of the ureter. Above the pelvic brim or the proximal is the upper and middle 1/3. Okay, so the upper 1/3 is pretty difficult. Obviously, this is just like any blood vessel. If you put tension on it, it's going to leak. So there's a lot of things you can do. You can see there's a lot of ureterostomy words here and things like that. But the main principle here, don't skeletonize the ureter, always spatulate it, and always do it over a stent. Okay? So whatever you're doing with the ureter, always do it over a stent. Middle 1/3 of the ureter, you can start to do something called a Boari flap, okay, which we'll talk about in a second, which is to bring more of the lower GU tract up toward the ureter, okay? And then especially in the lower third of the ureter, you can think about the easy things, which are reimplantation or psoas hitch. So a Boari flap is where you take a piece of the bladder and you just make it into a little tube, okay? So you cut out a little tongue, you sew the two edges up, and then you kind of implant the ureter in that. And again, over a stent, okay? Over your double J stent. So that, again, this is useful for things that are in the lower or middle 1/3 of the ureter, okay? Psoas hitch is only for the lower third of the ureter, and that's in this picture on the left-hand side of the screen there. So instead of bringing the ureter down, you're hitching the bladder up, okay, and you're hitching it to the psoas muscle, and then you're directly reimplanting your ureter through the bladder and sewing up your bladder. So that takes tension off your reimplantation, okay? So say you do that and you have this bladder injury. What about the bladder itself? How do we fix the bladder? So the great thing about the bladder is that if it's extraperitoneal, you don't need to do a thing. It's a low-pressure system. You widely drain it. How do we widely drain a bladder? With a Foley catheter, okay? And that does not require an operation, all right? However, if it's intraperitoneal, as we talked about a little bit before, your guts are now bathed in urine, which is a suboptimal situation, okay? And remember that you always have to be suspicious of this with pelvic fractures, okay? So it's a lot of transfer of energy. Your pelvis is a pretty difficult bone to break. You don't want to miss this. So what are the signs where you are suspicious that someone might actually have a bladder injury? The number one thing is going to be that they can't void. Okay, so the number one thing is going to be that their bladder is either full and they can't void, which might be a bladder injury, but it might also be a ureteral injury or a urethral injury. The second thing is going to be that they can't void, and then you get an ultrasound and their bladder is empty. Okay, and that is very concerning. So gross hematuria does not correlate with the degree of injury, but it obviously correlates with the presence or absence of injury. Okay, so grossly clear urine without a pelvic fracture means that a bladder injury is almost impossible in blunt trauma. Okay. So obviously the key thing here is going to be a cystogram. If you're on the fence and you're not in the operating room, CT cystogram or traditional cystogram, just fill that bladder up. Make sure that if you're not getting a CT cystogram, you get a post-drainage film, okay? So you might have an injury to the back of the bladder that you can't see when the bladder's full, and after you release all that contrast from the bladder, get another film and make sure there's not contrast remaining in that pelvis, okay? And again, you can do this by CT though, and we frequently will, okay? So you have to have also, to get this, you have to have also made sure that you don't have a urethral injury because this requires a Foley catheter, okay? So extraperitoneal, you can see that it's sort of confined to the pelvis there. There's a little bit of a shelf on that right-hand side. Intraperitoneal, you can see the outline of the bowel. Obviously concerning. All right. So contusions to the bladder, basically don't worry about them. They may have a little bit of hematuria. As long as you've ruled out any other injury, it's okay. Extraperitoneal injuries, we talked about. The majority of them you're going to be able to do just Foley catheter drainage. There are some absolute indications to repair. I would say that the number one that comes to mind that I can think of would be if you have an associated pelvic fracture and you get a leak through that. Okay, if you start to develop a urinary leak around that pelvic fracture, that would be an indication to go in and repair something, even if it's extraperitoneal. Okay, so how do we repair the bladder? It's actually pretty simple. Don't tell the urologist, okay? But it's, you know, you have your drain in, which is your Foley catheter. You go ahead and close it in 2 layers. Try to use absorbable. I like to use a stay suture on either side to kind of bring things up toward me, okay? And then you leave a drain. If you're concerned that it'll leak, leave a drain, okay? Follow up. Make sure the patient knows that they're going to have that Foley catheter. Get a cystogram in about 2 weeks, okay? If they still have extravasation, obviously leave your drains in place. Get another cystogram. All right. Okay. Questions. So a 27-year-old male arrives in the trauma bay after a motorcycle collision. He has a noticeable straddle injury with laceration and hematoma in the perineum, and pelvic radiograph identifies bilateral pubic rami fractures. There does not appear to be any blood at the meatus. What is the next step in management of an otherwise stable patient? Okay, so he's stable, but he's got perineal hematoma and bilateral pubic rami fractures. Go ahead and put the Foley in. Do not put the Foley in. Do not put the Foley in, okay? So this is very common after a motorcycle, especially where it's like those like Yamaha, like crotch rocket type motorcycles, okay? Not like a Harley Davidson where there's like space in front of the seat. So this is something where you have to have a high index of suspicion, and even though there's no blood at the meatus, if he has a pelvic injury and he has hematoma and laceration in the perineum, which means it might potentially be an open pelvic injury, you need to rule out urethral injury, okay? All right. So, now we have a 23-year-old who's hit from behind. She's who's in a car hit from behind. She's hemodynamically stable, and a CT of the abdomen pelvis is performed after arrival to the ED. The CT scan reveals no contrast in the mid-ureter and mild extravasation at the proximal ureter. So you know the diagnosis already. What's your next step? What should we do? She's hemodynamically stable, and she's got a defect in her mid-ureter. Just take her to the ICU? Probably not. We should probably fix it. Okay, so remember, this is going to be freely leaking urine, and if you leave it there, that ureter is going to stenose down, and the likelihood that you're going to be able to repair it later is much less. So if she's stable and she can tolerate a ureteral repair, she's likely to have a better outcome if you do it right away. Okay? All right. Which of the following findings or characteristics necessitates operative management in a patient with blunt hepatic injury? So which of these will make you go to the operating room? Blunt hepatic injury. So we didn't mention anything about age, right? Certainly, arterial blush never makes us go to the operating room, but it might make us go to IR. Concomitant splenic injury, we don't always have to operate on concomitant splenic injury, right? Grade 4 or 5. So remember, grade 4 or 5 sounds very scary, but you are always going to be releasing that hematoma when you go to the operating room, and there's going to be very, very few operative managements that you can potentially do. So if that patient with the grade 4 or 5 responds to transfusions and is relatively stable, try to leave it alone and let it clot. Try to maintain their physiology non-operatively, support them, prevent them from getting cold, prevent them from getting acidotic, and try to leave them where they are. Okay?